Hi, I'm Daniel Rosenbaum, intensivist at Indiana University. I'm here today to talk about one of the many applications of esophageal pressure monitors in managing patients with ARDS. Specifically, we'll see how we can use this tool to refine our assessment of the risk of ventilator-induced lung injury. I do have a disclosure. I created an online mechanical ventilation course. However, it's free and I don't receive any financial compensation for it. We'll start the presentation with a case. You have a middle-aged, morbidly obese female with ARDS from MRSA bacteremia. She's profoundly hypoxic. As you increase PEEP, you'll note an improvement in static compliance. PEEP is now 14 and your plateau is 35 centimeters of water. You'll know that if you keep up titrating PEEP, inevitably the plateau will rise even further. So you ask yourself, what should I do? Should I continue going up on PEEP to potentially maximize lung recruitment, or should I keep it as is to avoid going up on the plateau even higher above our usual safety limits? To answer this and other questions, in today's video, I'll discuss first why the plateau is a safety parameter in mechanical ventilation. Then we'll go over what the plateau fails to account for and what a more refined marker of safety could be. Then we'll learn how to apply this alternative parameter of safety. And we'll examine when to use this application of esophageal pressure monitors in clinical practice. Let's get started. A key principle in ventilating patients with ARDS is to avoid inflicting further lung injury by minimizing alveolar stress and overdistension. The plateau is a marker of safety because it is a surrogate for end-inspiratory alveolar pressures. It makes sense having high end-inspiratory alveolar pressures pose the alveoli at risk for overdistension and injury, like you can see in the picture. However, is it the pressure inside the alveoli what actually distends them? To answer this question, I'll use an analogy. Imagine you have a balloon connected to a straw, and you keep inflating the balloon until it bursts when the pressure inside it reaches 40 centimeters of water. What do you think would have happened, though, had the balloon been submerged? Do you think it would have burst at the same pressure? Certainly not. Why? Well, because what actually distends an elastic structure is not the pressure inside it, but the pressure across its walls. Here, the pressure inside the balloon minus the hydrostatic pressure surrounding it. And if we apply the same idea to alveoli after tidal inflation, the pressure inside is the plateau, and the pressure outside is the end-inspiratory pleural pressure. Their difference, the so-called end-inspiratory transalveolar pressure, reflects the true distending pressure of the alveoli, and therefore is a more refined marker of safety than the plateau alone. Clinically, we try to keep it at less than 15 to 20 centimeters of water. But you may be asking, how can we actually calculate it? If we need to measure pleural pressures, how can we measure pleural pressures? Well, turns out that the thoracic esophagus, marked here with a red circle on the CT scan, is located adjacent to the pleural space. So when we place a manometer in it, simply a catheter with a balloon near its tip, like you can see on the plain film, the pressure the manometer measures is a reasonable surrogate for pleural pressures. So now that we can actually calculate the end-inspiratory transalveolar pressure, let's see how we can apply it to real cases of ARDS. In our first case, we can see in the first airway pressure graph that the plateau pressure was 33 centimeters of water. Moving to our second esophageal pressure graph, we can see that our end-inspiratory pleural pressure was 26. The third graph, the live subtraction of the first two, is our end-inspiratory transalveolar pressure, which is only 7 centimeters of water, comfortably within goal. In this case, despite the elevated plateau, we have no evidence of excessive stress being applied to the alveoli. The true distending pressure is low. This information is key because it allows us to first tolerate that elevated plateau, and second, pursue interventions that in this case are indicated but will raise the plateau further, like increasing PEEP, which in this case we thought that PEEP was suboptimal. So that's what we did. We raised it because we were more comfortable with our plateau despite being elevated. Now let's move to the second case, which is a continuation of our opening case. And here you can see that the plateau pressure was similar, 32 centimeters of water. However, looking at the end-inspiratory pleural pressure, we see that it was only 10 centimeters of water. So their subtraction, the end-inspiratory transalveolar pressure, was 22 centimeters of water. Unlike the prior case, here we do have evidence of excessive stress being applied on the lungs. So in a case like this, we must attempt to lower our end-inspiratory alveolar pressures, our plateau, which we can either do by decreasing PEEP or tidal volumes. In this case, we decided to drop tidal volumes from 320 to 280, dropping our plateau to 30 and our end-inspiratory transalveolar pressure to 19. Now, let's examine when we would use this application of esophageal pressure monitors in practice. Although a well-designed trial failed to show any benefit from the use of esophageal pressure monitors in patients with ARDS, it still seems reasonable physiologically to use this tool in the subset of patients with suspected elevated pleural pressures. Pleural pressures drive chest wall expansion, so they'll typically be elevated in those with poor chest wall compliance, such as patients with severe obesity and elevated intra-abdominal pressures. To summarize, consider measuring end-inspiratory transalveolar pressures in patients with severe RDS and an elevated plateau when you think they have risk factors for having high pleural pressures. Use this information to stratify the risk of ventilator-induced lung injury. In patients with a high plateau and an end-inspiratory transalveolar pressure above goal, you should attempt to lower their plateau. They are at a high risk of VILI. In those with a high plateau but an end-inspiratory transalveolar pressure within goal, it is likely okay to tolerate that plateau and potentially even pursue interventions like increasing PEEP that may raise the plateau further if otherwise indicated. Make sure to scan the QR code for my references and additional learning material. Thank you.